Hello listeners, welcome to Views on Health. Tonight on the program we have Dr. Pravin Wijesinghe, consultant plastic surgeon, teaching hospital in Batticaloa in the Eastern Province, who's come to Colombo to be with you for the next nearly half an hour to discuss an important topic that has not been touched on for a number of years. And that is actually a number of years. We're talking about burns. A common mishap that people see across the board in homes, in places of work, elsewhere. Take a bad accident on the road. These things happen, and it's really traumatic, both for the person who's suffered the injury, the loved ones around, and definitely the medical personnel. They are human at the end of the day, and while they're there to treat you professionally, they also have their feelings that goes out to their patients, which in the long run, overall, helps in the healing process because they care, which is why they have taken to this particular aspect of medicine in the medical field to address this traumatic situation that people are unfortunate to face time and again. Having said that, by way of an introduction, a warm welcome to you, Doctor. Your first time in this series of programs, and we're really happy to have you with us. And the microphone is all yours to introduce this big, I would say a massive subject of burns.
Thank you, Fatima, and good evening to the listeners. When I was asked to think of a topic to sort of talk to you all about, burns came to my mind first because the burden of burns in Sri Lanka is massive, and every day we get burns. So in the course of this chat, I hope to sort of cover what a burn is, how it happens, the circumstances of it, what is done usually at home and what should not be done at home, and then what we do and how we look at it. So if you go to the technicalities, a burn basically is a tissue injury, and as soon as we say a burn, we mean skin, but it can involve any organ in the body. It can be the eyes, your mucosa, or any organ. When we say burn, we also generally mean a thermal injury, but in that broad term, it also covers chemical burns and also electrical burns, which we'll try to touch on a little bit as we go along. So as I said, it's a thermal injury caused by a flame, a hot contact, or a hot liquid that will damage skin to varying degrees, and that's basically what a burn is. So why are we talking about it? As I was telling you earlier, it's a big issue especially in the government sector, and I'm sure in the private sector too. We get burns coming from small fingertip burns to these massive burns that are life-changing and at times leads to the death of the patient. So we need to sort of know a bit about it. Everybody should know a bit about it to sort of manage it. So if you look at the causes of burns, causes at different age groups are different. So if you look at the pediatric age group, the commonest cause of pediatric burn is liquid burns. So it's hot oil, hot tea, hot curry, hot water. Generally, it's a child that pulls on a tablecloth and pulls down the kettle on themselves. And they're big burns, but the good thing about, if you can ever think of a burn to be a good thing, the good thing about a hot water burn is that it is generally superficial rather than it being a deep as with other burns. The other cause of thermal injury is contact burn, and a classic example is this silencer burn that occurs in anyone who rides a motorbike. So this hot metal comes in contact with the leg of the patient and causes a very deep burn. Of course, any person that cooks would know from experience that those small burns are very, very common. And the other big form of cause of burns is flame burns. And flame burns are actually a big problem in Sri Lanka because we have one of the highest suicide rates in the world, and that's a very common method of suicide in Sri Lanka. And those burns are covering more than 50% of the body, and they can be life-threatening in most of the times. So it's always good to know how it happens. Again, we do not get these very superficial burns which happens in foreign countries like these sunburns, because we do not go into the sun and we don't sunbathe as such, but those are those superficial burns that can happen. The circumstance of burns can be accidental most of the time, but unfortunately we do have a lot of suicidal burns in Sri Lanka, and very rarely the burn can be due to a homicidal intent. And most of these homicidal intents are acid burns, where they throw acid onto the face of generally young, good-looking people. When we get a burn coming to us, we look at them in a very scientific manner. So first thing what we do is we look at how it has happened, because each cause of burn causes the burn in a different way. We also look at the effect of it, because as you can imagine, the skin that gets burnt is the barrier we all have. It's the barrier against fluid loss. It's the barrier against hypothermia. It's the barrier against infection. So if the barrier is lost, all these three things can happen. We can lose fluid and cause fluid imbalances in the body. You can lose heat, causing hypothermia, and you can lose the barrier for infection, which basically puts you towards an infection. So, and in the long run, most of these burns can cause scars, and these scars can be terrible at times, causing contractures across joints, contractures across movable areas like the neck, the mouth, the eyes, the lips, and can be horrific with regards to the appearance of it. The next thing that we look at with regards to a burn is the percentage of burn. So a fingertip burn could be less than 1%, whereas a suicidal burn could be up to 60%. The latest one I have treated was about 95%. And so the percentage of burns is extremely important. First thing to tell us whether this patient needs admission. So we have a criteria to say less than anything more than 10% in a child, or anything more than 15% in an adult needs admission. And of course, it can also prognosticate the outcome for the patient, because the bigger they are, the worse they are. And so that is something that we look at. There are lots of ways of doing it, but generally we look at this rule of nines, where each part of the body has a certain percentage, and when that gets involved, we calculate and we add that as a whole. The other thing that we look at is the depth of burn. Now this is really, really important, and this is again a bit of a technicality. First, the most superficial area, which is called the epidermis, when that gets burnt, we call it a superficial burn. If the entire thickness of the skin is involved, and anything that is beneath that is involved, it's called a full thickness burn. But most of our burns fall in between, and that's where we say a grade 2 burn or a mixed dermal burn, where different thicknesses of that dermis gets involved. This is important because the superficial burns heal without much surgical treatment. Generally, all it needs is a pain relief and something to keep it protected while it heals. But a full thickness burn, on the other hand, almost always invariably needs a skin graft, where we take the skin from another area of the body and we cover that area. In the middle lies that gray zone where some heal, some don't, and that's where the clinician's skill come into play, where they assess and then decide. There are specific areas in the body when burnt can be a big problem. It's obvious that the face is one, and there are so many things that you need to think of. Face is an aesthetic organ. We look at that. That's what people see. We convey emotions through it. And when that gets burnt, we need to try and bring that to what it was, as close to what it was as possible. So when the face is burned, we are worried about the airway, the lips, the nose, especially the eyes, to see whether they are burned, and those need to get assessed. Hands are another very specific area, because hands also convey emotion. It's an aesthetic organ. Hands are beautiful as far as the plastic surgeon is concerned, and they are functional. They are what we are. We are not simian, but human because of our hands. So anything that causes the function of our hands to deteriorate, it's a concern. Of course, like similarly, the perineum, the feet are also specific areas that we need to look out for. When patients get burnt inside closed environments, we get this thing called an inhalational injury, which is life-threatening. So we also look out for such signs and symptoms to suggest that this could be an inhalation injury where the airway gets burnt. Talking about what we can do, what we should do when the patient, when there's a patient at home, or somebody from your family, or whether it's you as the patient. First thing to do is stop the burning. I mean, sounds pretty obvious, but what we always do is we try to put off the flames, but what we don't realize is our clothing, the jewelry we wear, watches or a ring, could be the source of burn to continue. So because these retain heat, and it's important that we always take those objects out of the body. If you're in an enclosed space or car, you obviously need to move away from that. There's this saying where we tell them to stop, drop and roll, and that's probably what we should do if it's like a big burn that's happening. If you're seeing someone burn, try to cover them, because that cuts off the oxygen to the burn, and that should take out the flames. Cooling is another very important thing that we at home should be thinking of. So the cooling will stop the burn from progressing. What's happened has happened, but we do not want to contribute to it spreading. So cooling basically involves taking tepid water, which is just tap water. And all we need to do is make sure that the tap water is run over the burn for a period of at least 20 minutes. Now, most of the people do a bit of cooling, but generally it's for 5 minutes or in and out, which is inadequate. So what we say is, as clinicians, what we say is always cool it for at least 20 minutes. Remember when I said the skin has functions? So now that we've got that burnt, those functions are lost. So the next step is to protect the patient from further deterioration, which basically means cover the patient. Don't keep the patient exposed, because the patient can go into hypothermia. And
a question, Doctor, at this point in time. That was a very detailed explanation and an introduction to burns and the test of types of burns, how they happen, and the extent of impact it will have on the body, various parts of the body. And what I wanted to know is that you just spoke of at least 20 minutes of cooling if it happens in the house, or wherever for that matter, to the best of their ability. People around should help. Of course, there are cases where the patient can be all alone, there's no one to help, and may not even be able to get to the water in the house or wherever, except maybe try to alert somebody, which also one doesn't know how much one can do in such unfortunate situations. In the meanwhile, while this cooling is taking place, shouldn't measures be taken to rush the patient to hospital?
Yep.
I just want to clarify that point.
So I say as soon as possible. As soon as possible, when the patient is safely out of the burning process, patient needs to get to a hospital. We do get a lot of patients coming days after, when the burn has basically no cooling has been done soon after the burn, and when the protective function goes away, the patient gets introduced to an infection. So they come with infections, and they come days after. And we would always suggest, even if it's a small burn, sometimes a small burn can be the cause for a big infection. So we always say that you should go to the hospital or the nearest clinician as soon as possible.
So that's a point that needs to be emphasized,
Yes.
that they need to get medical attention immediately, at the earliest they possibly can.
Yes.
Because now, going by what you just said, Doctor, I think mistakenly people must be trying home remedies, which is why they stay X number of days before they come to you,
Yep.
by which time a lot of damage is set in.
Yep. So I mean, I do get the fact that there are lots of reasons for patients presenting late. It could be that the patient might be alone, it might be in the middle of the night. It could be that they're far away where there's no transportation available. And they do try various home remedies. And one of the commonest things they try is, I don't want to even mention these sometimes because they might think that I'm suggesting it. One of the commonest things they try is actually toothpaste. Because I'm sure toothpaste feels cool inside your mouth, so they must be thinking that it will cool the burn. It's probably the commonest thing they use on burns. They also use honey. In the East Coast, they use various leaves that are burnt to a crisp, and the ash is used as a home remedy. I say don't put anything. They put butter. A lot of people put butter, especially here in Colombo. I think a lot of people do put butter. I'd say no. Even if you do not need to put, if the patient has got burnt, let's say 1 o'clock in the morning, till 6 o'clock, you do not need to put anything. Just come to the hospital at 6 o'clock in the morning. Do not put things, because one thing, now we need to then start removing this new paste, whatever it is. Number one, and also these are never sterile, and that can be a source of infection. So what we say is come to a hospital, come to the clinician as soon as possible without putting anything, but do cover. In areas of Colombo who can access cling film. Cling film is something that the Westerners suggest us to use, but I mean not everybody's got access to cling film. I'd say just cover it with a clean piece of cloth, come to the hospital, and we'll sort it out.
Thank you for that point, because I don't think very many people are aware that they need to cover the burn till they get to hospital, in the process of coming to hospital, to be covered with something that is to prevent that area from being exposed to the elements.
Exactly. Yeah.
Okay.
So,
Doctor, just another question.
Yes.
A while ago you spoke of the thickness of the skin.
yes.
Very interesting, because from our perspective, lay people, the skin is not thick. If you know what I mean, it's just a very soft skin. So what is the thickness that you...
So
can you explain
the
that to us?
clinicians divide the skin into epidermis and a dermis. And the dermis gets further divided into two more layers, reticular dermis and a papillary dermis. Although it looks thin, it has many layers of cells. So the burns get divided into a superficial dermal, deep dermal, and a full thickness burn according to the depth of the burn. Now the assessment of the depth of burn needs practice, needs training, and that's what clinicians are trained to do. If you do not have any blisters, you feel the burn but you do not see the burn, that's probably a superficial burn. It's commonly seen in sunburns. That's why I said very rarely do we see superficial burns. If the skin looks as if it's leathery, it's white in color, there are no hairs, there are no blisters, that's most probably a full thickness burn. The full thickness burn, a classical feature of a full thickness burn is that it's painless. So the patient doesn't sometimes present, especially those silencer burns I was telling you about, they present late because they are full thickness burns. Anything in between, and a classic feature of a in-between burn or a dermal burn is blistering. As soon as you see a blistering, you know that it's not a superficial, it's probably not a deep. It's basically a mid-dermal burn.
Thank you, Doctor, because again, like I said, we are not fully conversant with the medical side of things. Anatomy, we might know up to a point, but then that is not proper knowledge. So it will be interesting for our listeners to know that the skin has layers. Though when you look at our hands, our legs, or face, we just see skin.
Yep.
And it doesn't mean anything.
Yep.
Because then if you have like a cut or something, it's like you cut into it because it's so soft.
Yeah. And also, the thickness of the skin changes with age. So the kids, the really, really young babies have very thin skin, and the older generation also has thin skin. In between, when you're young, the skin is more thick. Different parts of the body has different thicknesses of skin. Like the back skin in the back is thicker, and the skin in your hands and the face is much thinner. So thickness changes from place to place, from age to age.
Thank you, Doctor. You did speak of skin graft. We'll come to it later because that's another area that I have some questions for. Now, when you talk of what they should do and they shouldn't do, you quite rightly said they put something on that part of the body where they have suffered the burn, and they come to you, you have a first job is to remove that before you treat. So therefore, dear listeners, please do not put anything on a burn. That's solid advice from Dr. Pravin Wijesinghe, consultant plastic surgeon, who's speaking with us on the program today. And it's imperative that you listen and adhere to this simple but important bit of advice that you do not put anything on a burn except the cooling part of it, which is best by water, plenty of water for at least 20 minutes, and at the earliest seek medical attention, however small your burn is. Having said that, Doctor, we have to continue with your focus on step-by-step procedure in dealing with the burns.
Yep. So when the patient comes to us, we assess what I said. We assess the percentage. We also assess the depth of burn. We also look for things that are urgent. And they can be an inhalational injury, as I was mentioning before. They can also be a full thickness circumferential burn in your limbs. Now, this full thickness circumferential burn in a limb is an emergency. It becomes a surgical emergency as far as we are concerned. Inhalational injury is also an emergency in burns. Of course, the bigger the burn, the urgency of seeking medical attention is vital, and the earlier they come to the hospital, we can start our treatment. So the treatment of burns is very rational. You lose a function, you try to prevent, you try to regain that function till the skin is regenerated or replaced. So one of the first things that happens, as I said, is loss of fluid. So you need to replace the fluid. Now this replacement of fluid, if the burn is small, can be just our normal replacement where we drink as much as we can. But when beyond a certain point of burn, this burn needs IV fluids, intravenous fluids as treatment, because the patient starts losing fluid not only externally, the body undergoes changes where the vessel starts leaking fluid into other areas inside the body. So overall, the fluid volume inside the vessels is less. So fluid needs to be done, and this is done according to certain protocols that we follow. The fluid volumes that is given to these patients is massive, and that's why the earlier we start the fluid treatment, the easier it is for the patient and also to maintain the vital functions. Fluid volume inside our vessels is vital to the functioning of the kidneys and all the organs. If the fluid volume is not replaced, these organs suffer, especially the kidneys, which can shut down due to fluid volume loss. The second thing we need to think of is we've lost a barrier function, and as soon as we lose the barrier function, if it spontaneously regenerates, we can wait. If not, we have to replace. And this replacement comes in the form of a skin graft, which we can talk about a little later. The other thing is these patients have a high metabolic rate. They need a lot more energy than they used to. So nutrition has to be followed, where we give a high protein diet, and most of these patients can have an oral regime, in the sense they can take food and fluids orally, but some of them need special care for the nutrition to be given. because they have lost the barrier function again, they are susceptible to infections, and so we might decide to give some antibiotics, but that is individually decided for a patient. Most important thing is dressing, so that more exposure does not occur, and that's where specialized units are ready for care of these patients.
Doctor, as time has caught up with us, we'll end this discussion at this point in time, but may we look forward to having you on the program next week too, when we can continue with this important aspect of burns and how to treat them, and you can advise our listeners on the next step that you will take from where we stop today.
Yes, so we have a bit more of details to talk about with regards to the management, about what a skin graft is and who needs a skin graft. But from what we've already spoken, what is key is how to manage them at home and the urgency of seeking medical help, which is essential for better care.
Thank you, Doctor. On that note of advice, we end this very interesting discussion on burns and place on record our grateful thanks to Dr. Pravin Wijesinghe, consultant plastic surgeon, Teaching Hospital, Batticaloa. Thank you so much, Doctor, for being with us on the program, and we look forward to your presence next week at the same time, when you can cover as much as you possibly can on this very, very wide topic of burns for the benefit of our listeners. Thank you so much.
Thank you.
Thank you also to Nadira Manam Peri for technical assistance. I'm Fatima Razik Kader, saying good night and hoping to be with you next Monday, same time on Views on Health.